Thank you very much, and good afternoon, everybody. This is really a pleasure to have the chance of summarizing to you what we think is the impact of our research on beating heart coronary surgery. Just to put you in a context, this is really a surgical treatment to treat patients with severe coronary disease, which remain in the UK and developed country #1 killer, with more than 800 heart attacks per 100,000 patients per year, more than 90,000 new cases of angina every year. Approximately in UK, 20,000 bypass operations are carried out every year. We are dealing more and more with patients with worsening risk profile. They are elderly, and they have more kidney function problems, diabetes, they have a poor pumping function of the heart, they are requiring more urgent or emergency operation. So this is a continual challenge, and trying to keep up with this challenge by refining our technique is of key to the success. So just to explain that coronary surgery has been conventionally done over 50 years in this way, so basically using heart-lung machine, which is a rather complex machine, which really takes over the job of heart and lungs, so that the heart can be stopped by giving it a special solution, and then an operation can be performed on it. So the rationale of beating heart surgery is basically about forgetting about heart-lung machine, and basically leaving the heart alone in the chest, beating and pumping around, sustaining therefore the blood circulation, while coming up with the surgical tools and new way of doing an operation on this beating and pumping heart to complete the bypass. And I think it's nice to possibly show you a small video. This is really one of the tools developed in Bristol. It's like resembling like the end of a sewing machine. So the heart is beating around, and really the focus on this area where the blocked artery is. And eventually, this has to be achieved, as we said, with the patient remaining in a stable condition. So normal blood pressure, no heart rhythm problems. And if this is achieved, then the safety of the procedure is, of course, achieved and can be carried out. And what we do then is the anastomosis, which is really the joining up of the blocked artery with the vascular conduit. So this is the blocked artery is cut open, and then there are what we call intracoronary shunt. There are silicone tubes which are inserted inside. You will see it in a second, an intracoronary shunt being inserted in this blocked artery. The heart is going in the meantime, and basically this is to ensure two things. First of all, that through this shunt, the distal part of the heart muscle is perfused, while we achieve a bloodless field, and the anastomosis can be done safely with some fine regular stitching. We have done more than 15 years of work on this research line, more than 10 trials, more than 10 large cohort analysis from our major data registry. The first thing was to really develop a reproducible technique to be able to train young surgeons. The next thing was to provide the evidence that this was something good to do. And basically, we did this in a very rigorous way by coming up, first of all, with a wave of small trials, focusing on the impact on each organ, so the heart, the kidney, lungs, brain. Then we came up with the large trials to focus on things like post-operative complications, on hospital research, on cost. We want to make sure also with follow-up that there was no late concern, and therefore these patients were followed up and are still followed up about 9 years after the large trials we did. And of course, we were training people. We want to make sure that the surgical performance of the trainees was of good standard. Of course, for reason of time, I can't give you all the impact produced by this research, but I'll give you a few snapshots. This is the first ever published trial on 80 patients coming from Bristol in 1999, and was focusing on the heart itself. And it's really this simple graphic showing you that we use a special marker called troponin I, which is a marker of myocardial cell injury. So you can see that the line of the beating heart shows virtually no release of this marker, whereas with conventional technique, there was a higher release. So there was a much better effect in terms of less myocardial injury on the heart. The other things which has been always fascinating for us to study is the brain. And it's been always difficult to image the brain, particularly at the microvascular level. We came up with this small further trial where we used the retinal, so the eye circulation, which is basically like an outgrow of the brain, to image it with this special technology, which is called retinal fluorescein angiography. Basically, a special contrast dye is injected to the patient, and then a special camera will allow you to take these fine pictures. You can look at the microcirculation and compare it before and after surgery. We could see that by doing the operation on the beating heart, there was a 55% decrease in retinal microvascular damage. This is an example of the damage we saw in conventional surgery. And by using another technique, we saw a 20 times less incidence of cerebral microembolization when surgery was done this way. Coming to postoperative complication soon after surgery, this was the target of the BACAS 1 and 2 trials, the first ever large trials to assess this type of outcome. We saw major benefit to patients, and particularly in terms of less postoperative complication like blood loss, transfusion requirement, chest infection, need of giving special drugs to the heart pumping function for recovery, less arrhythmias, and faster recovery. So major immediate effect compared to conventional technique. But then we, as I said before, followed up this patient. We want to make sure that there were no late concern. So what we did, we followed up this. This is a 7 years, this is just last year publication, 7 years follow-up. We used a special scan called CT, multi-slide CT scan, which really allow you to look at each graft performed a few years later and to see whether the graft is still fully working or is blocked. And really, at 7 years, the patency rate of this graft was 89% in each group, so no difference, and also no difference in terms of cardiac event-free survival, including death at 7 years. So the short summary here was major immediate benefit with no late concern. One of the impact we focused on BACAS 1 trials in 200 patients was hospital resource and cost. We could see a shortening of intensive care stay for 1 day on average, and hospital stay overall, again, 1 day. Our financial, economical assessment was focusing on specific direct cost variables, and in particular, when we put together really all the consumable required to do the operation in both ways, and also the consumable to deal with complications and transfusion, we saw a 25% saving per patient. That's to say, 4 patients were being operated at the cost of 3. And that's quite remarkable, also in consideration of the fact that this study did not take into account what we could call indirect costs, like, for example, professional fees. We've been training British young surgeons, but of course we've been having outside our doors a long queue of overseas surgeons coming to see what we were doing. Just to give you an insight on the impact of training and spreading locally, nationally, internationally, all of this started really due to the creativity, the leadership of one single surgeon, who's Professor Angelini, who's sitting here today in the room. Nowadays, 5 out of 7 consultants working in Bristol do their surgery on the beating heart, and this is really translated into this graphic. The red line is the percentage of beating heart coronary surgery, which is now up to 75%, equivalent to about 750 operations done every year in Bristol this way, with now an absolute number of more than 7,000 operations. Of course, we trained the UK surgical trainees, and they've been taking consultant jobs elsewhere in UK. They're now doing beating heart surgery at their new place, and they are training their trainees. We also had a look at what is the current percentage of beating heart coronary surgery in UK, and this is from the last National Adult Cardiac Surgery database, suggesting that about 17% of operations are now done this way in UK, and this is equivalent to about 23,000 operations. I was telling you about a lot of overseas coming to Bristol, and we have looked back and how many of them and trying to make out a figure. This is a first wave of people who came to Bristol between 2 to 4 years, so were fully trained in beating heart coronary surgery. Then they went back home. In each one of these cities, there is at least one surgeon trained in Bristol fully and is doing beating heart coronary surgery in his place. We also had established surgeons who came to Bristol for a few weeks to a few months to refine their technique and then going back home and implementing it. The current estimate is that 15 to 20% of worldwide coronary surgery practice is done on the beating heart. The work, of course, has been recognized in many ways during the years, in particular mentioning here the Surgical Team of the Year Award and Cardiovascular Team of the Year runner-up by Hospital Doctor in 2005 for work done on the beating heart surgery, and the John Parker Gold Medal by the UK Society of Cardiothoracic Surgery in 2001. My last slide is about acknowledgement. All of this would have not been possible without the dedication and commitment of few key individuals, and of course of few key institutions. University of Bristol, first of all, and the NHS counterpart, but also team of anesthesia, team of clinical and research nurses, the trial unit we have developed over the years in Bristol. This is really, perhaps to us, the most important local impact, which is really about creating a team, achieving a critical balance between this team, and in fact, it is based on this cultural change and educational process that we've been now taking up new challenges, for example, in the field of blood conservation, in the field of stem cell for myocardial repair, where we are running the first 2 world trials in acute and chronic MI. And I believe also it's one of the reasons why we have been awarded recently the Biomedical Research Unit in Cardiovascular Medicine by the NIHR. And of course, all of this would not have been possible without the generous funding by major charity, and I've listed a few of them here. Thank you very much for your attention.